Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was how to stay positive whilst my sister with a tracheostomy and severe pressure sores is in intensive care. You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to answer a very topical and current question that we get quite frequently as part of my one-on-one consulting and advocacy service in intensive care. How do they manage my loved one who is a COVID patient in ICU? Very topical, very timely. So SARS-CoV-2, the causative agent of coronavirus disease 2019, also known as COVID-19, is responsible for the largest pandemic facing humanity since the Spanish flu pandemic in the early 20th century. Since there is no specific recommended treatment, optimized support is the most relevant factor in the patient's prognosis. In the hospital setting, the identification of high-risk patients for clinical deterioration is essential to ensure access to ICU for intensive treatment of severe conditions in a timely manner. Early recognition of the patients who will require ICU admission and will benefit most from it is of utmost importance. What are the ICU admission criteria for adult patients infected with COVID-19? Authorities from the Chinese Center for Disease Control and Prevention reported that among more than 44,000 confirmed cases of COVID-19, about 81% were asymptomatic or presented mild symptoms such as cough, fever, fatigue, and muscle ache. Although for these cases, home management and self-isolation are the appropriate measures, 14% developed a severe form of the disease, and 5% were critical, requiring hospitalization and ICU admission, respectively. Admission criteria include oxygen requirements equal or superior to 6 to 8 liters per minute to reach a peripheral oxygen saturation of around 90 to 92%. Respiratory failure, shock, acute organ dysfunction or acute organ failure, patients at high risk for clinical deterioration, age greater than 65 years has been found to be an independent predictor of developing acute respiratory distress syndrome, also known as ARDS, or lung failure, ICU admission and mortality in several studies. Patients with comorbidities such as hypertension, diabetes, chronic obstructive lung disease, also known as COPD, chronic kidney disease, and malignant tumors have also been found to have a significantly higher mortality in patients with COVID-19. Moreover, patients with 2 or more comorbidities have significantly escalated risks of ICU admission, invasive ventilation, and mortality as compared with those who had single comorbidities, and even more so as compared with those without any comorbidities. However, in many countries, due to the shortage of ICU beds, usually only patients requiring intubation and invasive mechanical ventilation were admitted to ICU. Patients with a severe form of the disease must be closely monitored, since rapidly progression from moderate to severe ARDS may occur. Acute hypoxemic respiratory failure is the most common complication occurring in 60 to 70% of patients admitted to ICU. So, how is my loved one with COVID-19 treated in ICU? Number 1, non-invasive ventilation. Many hospitals have adopted non-invasive ventilation, also known as NIV, as an attempt to prevent respiratory failure from evolving into severe forms that require invasive ventilatory support. During this long COVID-19 pandemic outbreak, continuous positive airway pressure, also known as CPAP, and non-invasive ventilation NIV are being widely used to treat patients with moderate to severe acute respiratory failure. Initially, the treatment for severe respiratory failure included early intubation and invasive ventilation, as this was deemed preferable to be more effective than non-invasive ventilation, also known as NIV. However, emerging evidence has shown that NIV may have a more significant and positive role than initially thought. NIV includes continuous positive airway pressure, or CPAP, and also BiPAP. Current thinking suggests that NIV and high-flow nasal oxygen may be an appropriate bridging adjunct in the early part of the disease progress and may prevent the need for intubation or invasive ventilation. Positive responses are usually evident soon after the initiation of NIV and high-flow nasal prongs. However, if there is no substantial improvement in gas exchange and respiratory rate within a few hours, invasive mechanical ventilation should be started without delay. Now, and if you are wondering what is high-flow nasal prongs or high-flow nasal cannula, basically what that is, it's a nasal cannula and it's with a higher flow than the common nasal cannulas. It also is humidified and it can give higher concentrations of oxygen, up to 80% in some instances. And it also gives you a PEEP. Now, when you get BiPAP or CPAP, there is absolutely a PEEP. PEEP is basically a positive end expiratory pressure and it expands the lungs. And that in the past that could have only been done with invasive or non-invasive ventilation. Now with high-flow nasal prongs, you can also now give a low PEEP up to a PEEP of 5, and it helps expand the lungs. Next, the next treatment option for COVID-19 in ICU is prone position. SARS-CoV-2 viruses can cause a pneumonia that was identified through fever, dyspnea, and acute respiratory symptoms and named COVID-19. This disease exacerbates in a number of patients and causes pulmonary edema, multi-organ failure, and acute respiratory distress syndrome, ARDS, or lung failure. Prevalence of ARDS amongst COVID-19 patients has been reported to be up to 17%. Among the introduced treatment methods for management of ARDS patients, prone position can be used as an adjuvant therapy for improving ventilation in these patients. Research has found that when proning is used in patients with severe ARDS and hypoxemia not improved by other means, it has the benefit of better ventilation of the dorsal lung regions threatened by alveolar collapse. And alveolar collapse basically means that no gas exchange can take place in the lungs. If no gas exchange can take place in the lungs, the body is starved of oxygen, which will ultimately lead to cardiac arrest. Next, benefits of prone position: improvement in ventilation perfusion matching and potentially an improvement in mortality. Patients remaining in lengthy prone position sessions leads to decrease in mortality of patients. However, correct selection of patients and applying the proper treatment protocol for prone positioning are key to its effectiveness. Just quickly honing in there on prone positioning. When we prone patients in ICU, it's a massive undertaking. You need 5 to 10 people to prone a patient, especially if a patient is large, overweight. But even if a patient is a normal size, it's a large undertaking. You need to deeply sedate patients, often need to paralyze them. You need to make sure they're hemodynamically stable before you prone them, so they're not going into cardiac arrest while they're being prone, because you would have to turn them back on their back. It's a massive undertaking. You need to make sure patients are not getting pressure sores. You got to bolster those patients with foam, and as I said, it's a massive undertaking. And that comes with many risks. But the reality is that many patients with COVID-19 pneumonia or COVID-19 ARDS are being proned as a first-line treatment. Number 3, intubation for invasive mechanical ventilation. Most of the COVID patients admitted to ICU will finally require invasive mechanical ventilation due to diffuse lung injury and acute respiratory distress syndrome, ARDS, or lung failure. The main objective of mechanical ventilation in these patients is to maintain a lung protective strategy for all patients with ARDS, defined as targeting a tidal volume of 4 to 8 mils per kilo predicted body weight and a plateau pressure of less than 30 centimeters per water. And there's a nice little graphic that you can see below this video in the written version of this article. Also, when it comes to plateau pressure of less than 30 centimeters per water in the lungs, a pressure of higher than 30 centimeters per water in the lungs is really a risk for a pneumothorax or a barotrauma. You absolutely need to minimize the risk of high pressures in the lungs. It's very important so you don't end up again with barotrauma or pneumothorax, which would complicate matters. Number 4, analgesia, sedation and neuromuscular blockade management in patients with COVID-19. Patients with COVID-19 who undergo mechanical ventilation have an average recovery time of 1 to 3 weeks. The progress towards improvement is characteristically slow. Therefore, prolonged sedation is often unavoidable. In most severe cases of ARDS and also in cases of non-protective ventilation or in the occurrence of asynchrony, neuromuscular blockage is useful and complications such as polyneuropathy of the critically ill patient are usually diagnosed. Specifically, neuromuscular blocking agents can be helpful during endotracheal intubation to minimize the risk of patients coughing and possibly infecting healthcare personnel. Neuromuscular blocking agents can also be used in patients to promote patient ventilator synchrony while reducing the driving pressure needed with mechanical ventilation, particularly in patients with severe clinical presentation. Prone positioning has also become a cornerstone in managing refractory hypoxemia in patients with COVID-19 and ARDS, and neuromuscular blocking agents can be useful in facilitating this maneuver. Also, I should also hone in on endotracheal intubation is, it says here, can be helpful during endotracheal intubation to minimize the risk of patients coughing and possibly infecting healthcare personnel. And that is accurate. Now, you might have heard me mentioning earlier that the first line treatment is often BiPAP, CPAP, sometimes high flow nasal prongs. Now, some ICUs I know, especially in the early days of COVID, have gone to early intubation as early as when someone was on 6 liters of oxygen. And why was that? The reason some ICUs have intubated much earlier than pre-pandemic is simply that when someone is intubated, you have a closed airway. The risk for healthcare personnel getting infected with a closed airway is much lower compared to when there is an open airway with BiPAP or CPAP or high flow nasal prongs, patients coughing aerosols in the air. And obviously, as we all know now, COVID-19 is transmitted through the air as well, through aerosols. So the risk for healthcare personnel to get infected was through the roof. Now, again, this was pre-vaccinations. Now that most healthcare personnel is vaccinated, the risk has lowered. But the vaccine, as we all know, doesn't stop people from contracting COVID either. So you can see why some ICUs in the early days would have intubated early, whereas now that healthcare personnel might be a little bit safer with the vaccine. Now we're moving towards later intubation. Number 5, use of vasopressors or inotropes. Norepinephrine, also known as noradrenaline, is the first-line vasopressor in patients with hemodynamic instability and COVID-19. In patients with ARDS or lung failure, norepinephrine or noradrenaline also can improve heart's right ventricular function by restoring mean arterial pressure and thus right ventricular blood supply. If norepinephrine is unable to achieve adequate mean arterial pressure, vasopressin could be added as a second-line vasoactive agent to reach the target blood pressure. Vasopressin might be used as first vasopressor, mainly in cases of atrial fibrillation, pulmonary hypertension, and acute renal failure. Number 6, antiviral therapy. Several drugs have been studied for the treatment of SARS-CoV-2 or COVID-19. Most studied antivirals in this scenario were the combination of lopinavir, ritonavir, and remdesivir. Currently, the antiviral therapy that appears most promising is remdesivir. Remdesivir has been used recently on a compassionate basis due to a lack of proven efficacy drugs. A multi-center randomized clinical trial, RCT, including 1,063 patients receiving remdesivir or placebo, showed that remdesivir use led to a significantly shorter duration of hospital stay, 11 versus 15 days, and lower mortality, 8% versus 11.6%. The FDA has approved this drug for urgent use in COVID-19. Number 7, use of corticosteroids or use of steroids. The use of steroids reduces mortality in COVID-19 patients needing respiratory support. The trial showed that dexamethasone 6 mg once a day for 10 days results in lower 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen. Patients with severe COVID-19 can develop a systemic inflammatory response that can lead to lung injury and multi-system organ dysfunction. It has been proposed that the potent anti-inflammatory effects of steroids might prevent or mitigate these deleterious effects. Number 8, nitric oxide inhalation as an interventional rescue therapy. While there is no specific recommended treatment for COVID-19, nitric oxide has the potential to be of therapeutic value for managing acute respiratory distress syndrome in patients with COVID-19. However, inhaled nitric oxide has not yet been formally evaluated. Given the extent of the COVID-19 pandemic and the large numbers of hospitalized patients requiring respiratory support, clinical use of inhaled nitric oxide may become an alternate rescue therapy before extracorporeal membrane oxygenation for the management of acute respiratory distress syndrome in patients with COVID-19. You might have also heard of extracorporeal membrane oxygenation as ECMO, and I'll come to that in a minute. Next is ECMO therapy. ECMO stands for extracorporeal membrane oxygenation, is effectively an artificial lung or an artificial heart. The technology is used when all other forms of heart and lung support have failed for critically ill patients. It works by temporarily drawing blood from the body to allow artificial oxygenation of the red blood cells and removal of carbon dioxide with a machine. Now, the treatment is being used to support critically ill patients with COVID-19 pneumonia or COVID-19 ARDS for whom ventilation is insufficient to sustain blood oxygen levels. COVID-19 is one of the most challenging health emergencies we have faced this century. Health professionals are experiencing very, very difficult times with limitations of resources and information, which, when available, needs to be confirmed before integration into clinical practice. To date, there is no proven specific treatment for the management of COVID-19, although studies with promising results have recently emerged. We know already that the lowest rates of mortality are related to better quality of care. Early diagnosis, application of effective therapies and adequate strategies of clinical stratification are needed for better outcomes in COVID-19 patients. And there is a whole line of references below this video in the written version of the article. Now, I also want to quickly hone in on that, whilst these are current treatment options, the reality is this: COVID-19 has only been around for 2 years now, and in 5 years' time we have a lot more data. There will be a lot more data available. We're still, in the experimentation phase of how COVID-19 is being treated, I believe. What I would also say is that, generally speaking, patients that go into ICU with COVID, what we've seen now is they often get into ICU with COVID pneumonia that can then often develop into COVID ARDS. Some patients are being admitted with ARDS straight away. What we're also seeing is that when they stay in ICU for a while, they also end up often with a bacterial pneumonia, and then they're being treated with antibiotics, or sometimes it might be a fungal pneumonia as well, and then they're being treated with antifungals as well. Also, just quickly want to come back to the neuromuscular blocking agents in ICU and why this is being used. It's often being used when sedation is not enough to have a patient breathe against the ventilator, because the last thing you want is someone with a pneumonia or ARDS fight against the ventilator, and that's why patients are often being paralyzed. so they're not fighting against the ventilator. And number two, when you prone a patient again, when you turn them on their tummy, on their stomach, it can be very uncomfortable. And therefore, you need to paralyze them so they're not fighting against the ventilator, because getting adequate ventilation therapy in those situations is very important. Okay, that's it in relation to how COVID-19 is being treated in intensive care. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, have peace of mind, control power and influence quickly whilst your loved one is critically ill in intensive care? Well, you will get to that all-important feeling of making informed decisions, get peace of mind, control power and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to quickly make informed decisions, get peace of mind, real power and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control power and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what is really happening in intensive care, and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or send me an email to support@intensivecarehotline.com with your questions. Also have a look at our membership site, intensivecaresupport.org, for families of critically ill patients in intensive care. You can also call us, find phone numbers on the top of our website. Also have a look at our ebook section, and you can get one-on-one consulting and advocacy with me over the phone via Skype, via Zoom and via email by clicking on the relevant tabs on the top of the website. Thanks for watching. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.